This balloon just saved my patient's life. And if you don't understand how it works, you could accidentally kill yours. What you're looking at is an intra-aortic balloon pump. And in the next 15 minutes, I'm going to show you exactly how this incredible device can increase cardiac output by 20%, reduce myocardial oxygen demand by 30%, and literally buy time for a failing heart to recover. But here's the scary part. One wrong setting or missed complication can turn this life-saving device into a deadly threat. Hey everyone, welcome back to NurseBrain. I'm Neil Brian Galve, and if you work in a cardiac ICU, CVICU, or anywhere you might encounter critical ill cardiac patients, this video could be the difference between confident, competent care and dangerous uncertainty. Here's what most nurses don't realize about the intra-aortic balloon pump. It's not just another piece of ICU equipment. It's a sophisticated hemodynamic support device that requires specialized knowledge to operate safely. I've seen nurses who understand IABP therapy catch early signs of limb ischemia, recognize timing problems, and prevent catastrophic complications. I've also seen nurses who don't understand the device miss critical warning signs that cost patients their limbs or lives. The IABP is the most widely used mechanical circulatory support device in the world, with over 160,000 patients receiving this therapy annually. But despite its widespread use, many nurses feel intimidated by the complex waveforms, timing, adjustments, and potential complications. So today, we're going to master the IABP from a nursing perspective. We'll cover the indications, contraindications, mechanism of action, nursing management, and the critical assessments that separate competent cardiac nurses from exceptional ones. Let's start with the basics. What exactly is an intra-aortic balloon pump, and how does this remarkable device support a failing heart? The IABP consists of polyurethane balloon wrapped around a catheter that's positioned in the descending thoracic aorta, just distal to the left subclavian artery. This balloon is connected to an external console that inflates and deflates it in a perfect synchrony with the patient's cardiac cycle. But here's where it gets fascinating. The IABP works on the principle of counterpulsation. During diastole, when the heart is relaxing and filling, the balloon inflates, displacing blood and increasing diastolic pressure. This enhanced diastolic pressure improves coronary perfusion. Remember, the coronary artery is filling during diastole. Then, just before systole begins, the balloon rapidly deflates, creating a vacuum effect that reduces afterload, the pressure the heart has to pump against. This makes it easier for the weakened heart to eject blood. The hemodynamic effects are immediate and dramatic. Increase coronary blood flow, reduce myocardial oxygen demand, improve cardiac output, and decrease left ventricular workload. It's like giving the heart a mechanical assistant that helps it pump more efficiently while using less energy. Clinical Pearl. The IABP doesn't replace heart function, it augments it. The patient's heart must still be beating for the device to work effectively. This is why it's called counterpulsation. It works in opposition to the heart's natural cycle to optimize hemodynamics. Understanding when to use an IABP and when it's contraindicated is crucial for safe patient care. Let's break down the indications first. Cardiogenic shock is the most common indication, especially when it complicates acute myocardial infarction. The IABP can stabilize patients until definitive treatment like PCI or CABG can be performed. High-risk percutaneous coronary interventions often use prophylactic IABP support. If the patient has severe left main disease, poor left ventricular function, or is the only remaining vessel, the IABP provides hemodynamic insurance during the procedure. Mechanical complications of MI, like acute mitral regurgitation from papillary muscle rupture or ventricular septal defect. are classic IABP indications. The device can stabilize patients until emergency surgical repair. Weaning from cardiopulmonary bypass after cardiac surgery is another common use. Some patients need the extra support to transition from the bypass machine to their own cardiac function. Now, for the absolute contraindications, these are the situations where IABP use could be fatal. Aortic regurgitation is the most important because balloon inflation during diastole would worsen the regurgitation and potentially cause acute heart failure. Aortic dissection is another absolute contraindication because the balloon could extend the dissection or rupture the aorta. Severe peripheral vascular disease may prevent safe insertion or cause limb ischemia. Relative contraindication includes severe bleeding disorders, recent stroke, and severe aortic stenosis. These require careful risk-benefit analysis. As the bedside nurse, you're the eyes and ears of the IABP team. Your continuous assessment and monitoring can prevent life-threatening complications and optimize patient outcomes. First, let's talk about hemodynamic monitoring. You need to understand what good augmentation looks like. The augmented diastolic pressure should be higher than the patient's unassisted diastolic pressure, and you should see a reduction in the systolic pressure after balloon deflation. Timing assessment is crucial and something many nurses struggle with. Look at the arterial waveform on the console. Proper timing shows a sharp diastolic augmentation peak that's higher than the systolic pressure, followed by a reduced systolic pressure after deflation. But here's what's critical. You need to recognize timing problems. Early inflation causes premature aortic valve closure and increased afterload. Late inflation provides inadequate diastolic augmentation. Early deflation doesn't reduce afterload effectively. Late deflation increases afterload and can impede ventricular ejection. Vascular assessment is absolutely critical because limb ischemia is one of the most serious complications. Check pulses, skin color, temperature, and capillary refill in the affected extremity every hour initially, then every 2 to 4 hours once stable. Watch for the 5 P's of ischemia: pain, pallor, pulselessness, paresthesias, and paralysis. Any of these signs requires immediate physician notification because limb loss can occur within hours. Patient positioning is important but often overlooked. Keep the head of the bed at 30 degrees or less to prevent balloon migration. The affected leg should remain straight to prevent catheter kinking. The IABP complications can be life-threatening, but early recognition and intervention can prevent catastrophic outcomes. Let's go through the major complications you need to watch for. Vascular complications are the most common, occurring in 2 to 20% of patients. These include limb ischemia, bleeding, hematoma formation, and arterial dissection. The risk is higher in women, elderly patients, and those with peripheral vascular disease. Here's what the research shows us. Thrombocytopenia occurs in about 50% of IABP patients, fever in 36%, and bleeding in 27%. These aren't rare complications. They're common enough that you need to be watching for them constantly. Balloon rupture is a serious complication that can cause gas embolism. Signs include blood in the helium tubing, loss of augmentation, and potentially neurological symptoms if gas reaches the cerebral circulation. If this occurs, immediately stop the console and notify the physician. Infection can occur at the insertion site or systematically. Use strict aseptic technique for dressing changes and monitor for signs of local or systemic infection. The risk increases with duration of support. Console alarms require immediate attention. Common alarms include timing errors, pressure leaks, and ECG signal loss. Never ignore alarms. They indicate potential dangerous situations. Here's a critical nursing skills. Troubleshooting timing problems. If augmentation is poor, check ECG signal quality, verify trigger source, and assess balloon position. Sometimes, switching from ECG to arterial pressure triggering helps with arrhythmias. Caring for IABP patients involves more than just monitoring the device. You're caring for a critical ill person who's likely scared and uncomfortable. Pain management is crucial but often challenging. The insertion site may be painful. The patient must remain relatively immobile. Work with a team to provide adequate analgesia while maintaining hemodynamic stability. Psychological support is equally important. Explain the purpose of the device, the importance of keeping the leg straight, and what sensations they might experience. This reduces anxiety and improves cooperation. Skin integrity is a major concern with prolonged bed rest. Pay special attention to pressure points, especially the sacrum and heels. Use pressure relieving devices and reposition the patient as much as the IBP allows. Nutrition and hydration need attention too. These patients are often NPO initially, but as they stabilize, nutritional support becomes important for healing and recovery. Family education and support shouldn't be overlooked. Families are often frightened by the complex equipment and alarms. Take time to explain what they're seeing and hearing and involve them in appropriate aspects of care. Successful weaning from IABP support requires careful assessment of the patient's hemodynamic stability and underlying cardiac function. Weaning typically begins when the patient demonstrates hemodynamic stability, improved cardiac function, and resolution of the underlying problem. This might be after successful PCI, cardiac surgery, or medical stabilization. The weaning process usually involves reducing the augmentation ratio from 1:1 to 1:2, then 1:3. While closely monitoring hemodynamics, some patients may need to return to higher support levels if they don't tolerate weaning. During weaning trials, watch for signs of hemodynamic deterioration, decreased blood pressure, increased heart rate, reduced urine output, or symptoms of heart failure. These may indicate the patient isn't ready for weaning. Before removal, ensure adequate coagulation status. Patients on anticoagulation may need reversal or dose adjustment to prevent bleeding complications during sheet removal. The removal process involves deflating the balloon, removing the catheter, and applying direct pressure to achieve hemostasis. Manual pressure is typically required for 15 to 30 minutes, depending on the patient's coagulation status. Post-removal monitoring includes frequent assessment of the insertion site for bleeding or hematoma formation, distal pulse checks, and bed rest for 4 to 8 hours, depending on institutional protocols. Recent research has challenged some traditional uses of IABP, and it's important to understand the current evidence. The IABP Shock 2 trial was a game changer. It showed no mortality benefit for IABP and cardiac shock or cardiogenic shock, complicating acute MI when used routinely with early revascularization. This has led to more selective use in this population. However, IABP still has clear benefits in specific situations. Mechanical complications of MI, high-risk PCI, and weaning from cardiopulmonary bypass. The key is appropriate patient selection. Current ACC or AHA guidelines give IABP a Class 2A recommendation for patients with acute MI complicated by cardiogenic shock as temporary stabilizing measure, but they emphasize that alternative mechanical assist device may be considered for refractory shock. The research shows us that to achieve the best possible outcomes, nursing and medical staff require specialized skills. Your role in continuous assessment, complication prevention, and patient advocacy directly impacts outcomes. Quality metrics for IABP programs include complication rates, appropriate use criteria, and patient outcomes. Your role in monitoring and preventing complications directly impacts these metrics. Let me share some advanced tips that will make you stand out as an IABP nurse. Understanding the relationship between IABP, effectiveness, and heart rate is crucial. The device works best with heart rates between 60 to 120 beats per minute. Very fast rates don't allow adequate time for diastolic augmentation, while very slow heart rates may not provide enough support. Learn to correlate IABP pressures with clinical assessment. If the numbers don't match what you're seeing clinically, trust your assessment and investigate. The device is only as good as its positioning and timing. Understand that mean arterial pressure is often more reliable than systolic pressure for assessing perfusion in IABP patients. The map is what perfuses organs. Know your institutional policies inside and out. Different facilities may have different protocols for monitoring frequency, weaning procedures, and complication management. Finally, never hesitate to ask for help or clarification. IABP therapy is complex, and even experienced nurses encounter situations they haven't seen before. Alright, let's bring this all together. The intra-aortic balloon pump is a powerful tool for supporting critically ill cardiac patients, but it requires specialized knowledge and vigilant nursing care to use safely. Remember, the key principles here. IABP works through counterpulsation to improve coronary perfusion and reduce cardiac workload. Proper timing is essential for effectiveness and safety. Vascular complications are the most common and serious adverse events. Continuous assessment and monitoring can prevent catastrophic complications. Your role as a nurse caring for IABP patients cannot be overstated. You're responsible for recognizing complications, optimizing therapy, and ensuring patient safety. Your assessment skills and clinical judgment can literally save lives and limbs. The IABP may seem intimidating at first, but with proper understanding and experience, it becomes an invaluable tool in your critical care arsenal. Don't be afraid to ask questions, seek additional training, and always prioritize patient safety. If this video helped you understand IABP therapy better, smash that like button and subscribe for more critical care content that will make you more confident and competent nurse. And if you want to learn more about hemodynamic monitoring, check out this video on arterial lines. It's the perfect complement to IABP knowledge. Drop a comment below and let me know what's your biggest challenge with IABP patients. Have you seen complications that could have seen or that could have been prevented? I love hearing your experiences and helping you provide the best possible care. Until next time, keep monitoring those waveforms. Keep assessing those pulses, and remember, you've got this. Once again, this is NurseBrain, inspiring greatness one lesson at a time.